Okay, let's go ahead and get started. I'm going to talk about the pulmonary artery catheter and right atrial monitoring. Pulmonary artery catheters are also known as Swan-Ganz catheter. What are the reasons for a pulmonary artery catheter? One is to evaluate hypotension. When the origin or the etiology of the hypotension is not known, then this is a good way to determine what is going on in the cardiovascular system. It is also a very good way to measure or evaluate volume status, and therefore it guides us with fluid resuscitation. The third one is to differentiate cardiogenic versus pulmonary edema, also used effectively, particularly during surgery, to determine the effects of vasopressors and inotropes, as well as to evaluate left ventricular and right ventricular function. There is a contraindication. A relative contraindication is the presence of a left bundle branch block. So let's take a look at what the real reason is. So when this is the heart and this is the septum, right? The bundle branches are right at the side of the septum, right here. One on the left and one on the right, obviously. Now, when we're inserting a Swan-Ganz catheter, a pulmonary artery catheter, what could happen is that we could actually damage the right bundle branch. And therefore, if we damage the right bundle branch and you have a left bundle branch block already, what's going to happen is that the patient will go into a complete heart block. So if this is the case, due to the risk of right bundle branch block damage during catheter insertion, usually there's an external or a transvenous spacer that will be placed at the moment of the procedure to prevent complete heart block. I'd like to just say that the catheter, the pulmonary artery catheter, was named after Swan and Ganz. They're two cardiologists, and their favorite pastime is to go out and sail. Okay. So the reason why I'm saying this is it has something to do with how this pulmonary artery catheter, known as Swan-Ganz catheter, was designed. And they were sailing and they were saying, you know what, this boat moves pretty quickly because it depends on the wind, forcing it to move forward. And so they had an idea and they said, what if we had a catheter that we would insert into the right atrium. And then once we get into the right atrium, we're going to blow the balloon up and it will now be propelled by the movement of blood moving forward. And thus was born this kind of catheter, the Swan-Ganz catheter, or the pulmonary artery catheter. Insertion of the catheter is usually done from one of the main central veins, usually the subclavian or the internal jugular or the femoral vein. And then the catheter will now traverse into the superior and the inferior vena cava and reach the right atrium. From the right atrium through the tricuspid valve. This is passively now because we inflate the balloon once we get into the right atrium. The movement of the balloon will now follow circulation, and therefore it will go through the tricuspid valve onto the right ventricle, through the pulmonic valve, and then to a tributary of the pulmonary artery. So this is how we are now going to measure left-sided pressures. And you're going to say, how in the world are you going to measure pressures by inserting this catheter? So if we were to diagram the right side of the heart and the left side of the heart over here, and there's going to be the pulmonary arteries and the pulmonary veins right here, or the lungs, the concept here is that if I were to introduce a catheter that is going to be threaded into a tributary of the pulmonary artery, and I now occlude this particular artery, I can now therefore measure what is in front of this catheter. And what is in front of this catheter will be pressures coming from the left side. Now, we traditionally have said that this is an occlusive pressure that we're measuring, but in actuality, it is a downward pressure that we're measuring, a downward pressure reflecting the pressures coming from the left side. All right, so do we understand how or why we want to put a pulmonary artery catheter? It's a good substitute, putting a catheter on the left side. However, we don't want to put a catheter on the left side for longer periods of time, because this would mean to say that we would have to cannulate the catheter through arterial circulation. And therefore, this will represent a greater risk for the patient. So that is the reason why they designed this pulmonary artery catheter. My role now is to talk a little bit about the anatomy, or what is in this pulmonary artery catheter, so that we can understand how to use them, and also what precautionary measures have to be undertaken. There are several designs of a pulmonary artery catheter, and they range from a simple catheter that measures pulmonary artery pressures, and it could go to complex Lumen catheters that also measure cardiac output and other variables. Usually, this is a quadruple Lumen catheter. And in addition to this quadruple Lumen, it usually has a thermodilution sensor that is attached to a pressure transducer outside the body. And with this transducer, we're now able to determine pressures like central vein pressure, right atrial pressure, right ventricular pressures, and obviously pulmonary artery pressures. So the catheter size ranges anywhere from 60 to 110 centimeters in length. It could also come in 4 French to 8 French in caliber. So each of the 4 lumen is placed in a very specific distance to the length of the catheter, and each of them has a specific function. I had said that the catheter is usually 110 centimeters long, and there are thin black markers that you will see on the left side of the screen. I'm going to zoom in right there. These particular markings are very, very important. The thin line, if you see the thin lines, they're 10 centimeter markers, and the thick line is a 50 centimeter marking. So on this particular example, you would see that it's a 90 centimeter is this distance. So this is very important, because when you are taking care of a patient with a Swan-Ganz catheter, you would note the exit point of the catheter. Whatever is in the exit point determines how much is inside the body. If the distance marking, for example, located at the entrance of the introducer is 45 centimeters, then that means to say that 45 centimeters of the catheter is inside the patient. So there are several distances that usually are going to be very important. To the right atrium, the distance is 10 to 15 centimeters from the subclavian vein. And if you were using the jugular vein, it would be around 15 to 20 centimeters. And if it is from the femoral vein, it would be 30 to 40 centimeters. The distance to the right ventricle is going to be an additional 10 centimeters. So if it was from the subclavian, it would be around 20 to 25. And again, if it is to the pulmonary artery, the distance would be another 10 centimeters. So let's take a look at the components of the catheter itself. And one of those components is what is known as the side arm, or the side port of the introducer, and it is labeled right here. What can we use this for? Well, we can use this for continuous medication drips. If there are no continuous medication drips infusing, you could actually infuse normal saline to keep the vein open at 10 mLs per hour in order to prevent catheter occlusion. So that's the purpose of that. The other one is going to be your proximal injectate lumen, or your CVP port, which is this one. It represents the right atrial lumen. It actually is 30 centimeters from the tip of the catheter, and this would be, or the opening of this one, I should say, would be resting within the right atrium. when the tip of the catheter is in the pulmonary artery. So what can we use this port for? Well, it could be used for infusion. It could also be used to assess CVP and right atrial pressure because this is in the right atrium. And this is also the port that we would use if we do another method of cardiac output determination by injecting your injectate in this area. Now, by the way, it could also be used to draw venous blood some. However, there's one very, very important thing about this port. You should never use it to infuse any vasoactive drugs or other medications that need to be infused continuously. Because when you have to do cardiac output by injecting a certain amount of fluid in this area, you're going to interrupt the infusion, and therefore it would result in the patient receiving a bolus of medication. So if this is the only site that is available for administration of vasoactive drugs, make sure that you to utilize the proximal port, but do not perform cardiac output in here. In this particular port, actually, when they do cardiac output measurements, 10 ml of fluid is usually given into this port. And of course, if you give it and there is vasoactive medications in that line, then you're going to be pushing a bolus of this medication to the patient. Another lumen or another tail that you can see in this catheter is going to be this white clear lumen tubing right over here, indicated with a blue arrow. Now, this actually terminates at the 31 centimeter mark, and therefore it still lies in the right atrium. Remember, the blue port is at 30, so this is at 31 centimeters. This port is used for infusion of medications. You can use this particular port for medication drips. Actually, you could administer medication as soon as venous placement of the introducer has been confirmed by pressure measurements. The other port is going to be your yellow port. And so I'm going to zoom it in because it's going to be right here. This is the PA distal port. Well, this is the one that goes into the pulmonary artery lumen. And you usually would connect this to a transducer or a transduced hemodynamic monitor so that the waveforms can be displayed as the catheter passes through the chambers of the heart and into the pulmonary artery. This port does the measurement of the pulmonary artery pressure. Now, this port is also very, very important because it could be used to draw mixed venous samples. So if you need to draw a mixed venous blood from the pulmonary artery port, this is where you're going to do it, but you have to aspirate it slowly. The reason why you need to do it very slowly is because it's possible to collapse the catheter or perhaps to create a trauma to the wall of the artery. The patency of this lumen is achieved by maintaining a continuous flow of heparinized saline at a rate of around 3 cc's per hour. So there's one very important thing too. You should never inject anything into this lumen. No drips, no medications, no fluids ever. This is going directly into the pulmonary artery. The next anatomy of this one is the thermistor or the wire connector. It's this thing that's red. It's pointing right over here. So the temperature thermistor is located proximal to the balloon, right over, very close to the balloon, right over in this area. And it is to measure pulmonary artery blood temperature. It includes a temperature-sensitive wire, and it actually terminates at around 4 centimeters from the tip of the wire. So if this is the tip of the wire, 4 centimeters from it is going to be the thermistor. When you connect the thermistor port, this one right here, to a cardiac output monitor, you therefore allow for determination of cardiac output using thermodilution. I wanted to just illustrate to you why this method of cardiac output, which is sort of no longer used much, but it used to be used quite a whole lot. And so the idea was this. Okay, so if this is the catheter and the thermistor was here, the principle was if I introduce a solution a 10 cc of fluid right here. And let's say now, this is just hypothetical, that the temperature of that solution is 97. Now, as you push that solution, the amount of time it takes to get over here is going to be calculated as the cardiac output. And that time interval is going to be determined by the point or the time that the thermistor sends the temperature that you had introduced. So let's say I injected a solution at 97 degrees, and then the thermistor will now sense when it reaches its end, the time interval that it took for that solution to go from here, from the right atrium, all the way to the tip of the pulmonary artery is calculated as the cardiac output. So usually the catheter measures cardiac output by sensing the change in the temperature as the injectate flows over the thermistor. The thermistor actually can also be used to continuously monitor core body temperature. Core body temperature is most accurate. Another part of the catheter is your balloon inflation or lumen valve. That's the one that has a syringe attached to it. And I'm going to zoom to each one of them. So right here, as you could see, there is a port right over here where it is attached to a syringe, and it's right over there. Okay. This is the red port, and this is known as the balloon port. At the distal end of the catheter, there is a latex rubber balloon, and it can accommodate 1.5 ml only, which when inflated actually will extend slightly beyond the tip of the catheter. So if this is the tip of the catheter right here, the tip, the balloon when inflated will move forward slightly like this. And what is the purpose of that balloon? Well, the purpose of that balloon, again, is to underscore the principle upon which it's going to detect something. So if I have a catheter right here and there is an opening right there, what's going to happen is I can measure pressures coming from here, also pressures that are coming from this area. But what if you had a catheter, like a Swan-Ganz catheter or pulmonary artery catheter, and now you inflated the balloon and therefore you occlude this lumen of the artery? So basically, the catheter is going to be blind to pressures over here. It will only sense pressures ahead of it. And so if this is in the pulmonary artery, what are the pressures that are ahead of it? So again, in my illustration, this is the right heart, this is the lung, and this is the left side of the heart. So therefore, if you have a pulmonary artery catheter and you now have occluded it, similar to what I'm doing over here or illustrating over here, it will only therefore sense pressures that emanate from the left side of the heart, in particular the atrium, and when the mitral valve is open, possible also to have a reflection of ventricular pressures. All right, there are several functions of the balloon. Why is the tip of the balloon in the design? Well, I already mentioned one reason. The other reason that there's a balloon, the balloon, whenever you inflate it, will cushion the tip of the catheter, and therefore it will prevent its contact with the right ventricular wall during insertion. Let's say now that this is the right atrium right here, and this is the right ventricle. Imagine now if we inserted this catheter right here and go into the right ventricle without the balloon, what's going to happen is as the heart is beating, this tip of the catheter will be whipping the walls of the right ventricle. So if you whip the walls of the right ventricle, what's going to happen? If this is the walls of the right ventricle and the catheter is going like this, what's going to happen? You will have ventricular tachycardia and possibly ventricular fibrillation. And that is the reason why whenever this catheter is actually introduced right at the very start as soon as it enters the right atrium, the balloon is going to be inflated. And this balloon inflation will have two purposes. One is to guide the catheter all the way to the pulmonary artery. And the second one is to prevent this catheter from whipping the right ventricle. So it has one other important function then. Let's say now that a patient has a pulmonary artery catheter and it should be in the pulmonary artery, but sometimes it migrates. And so from the pulmonary artery, if this is the pulmonary artery, the catheter might migrate into the right ventricle. So if that happens, a nursing intervention would be to inflate the balloon. And the purpose of inflating the balloon is preventing dysrhythmias from happening. And number two, to allow it to be guided once again to go into the tributary of the pulmonary artery. So there are other important things about this lumen. There is a self-limiting syringe provided in the PA catheter kit. And this is designed to prevent the balloon from being overinflated. This syringe has a limit of 1.5 ml. You cannot introduce more than 1.5. What is so important then? The balloon should never be inflated with more than 1.5 mLs by substituting this syringe. Now, a lot of times this syringe might get lost. If it gets lost somehow or another, sometimes it gets along with the linens. You should not substitute it with a regular 2 cc syringe. That is going to be a very dangerous thing to do. The other thing that we need to emphasize is that whenever we inflate this balloon, the balloon should be inflated with a volume of 1.5 ml or less. It doesn't have to be 1.5. It is going to be inflated just enough to occlude the pulmonary artery. And in fact, the balloon should not remain inflated for more than 4 respiratory cycles, and therefore it is imperative that you remember that by inflating it for a longer period of time, you might cause a damage or rupture of the pulmonary artery. So when we're talking about pulmonary artery, we're not actually talking about the big artery, but rather a tributary of this artery. So if this is the pulmonary artery, and now it branches into smaller arteries like this, the pulmonary artery catheter is not in here. It actually, when you wedge it, it's going to be right over here. You're wedging this area. So once you are going to be successful in wedging it, then you should allow for the air to passively come out from the syringe. You never suck out the air that you had introduced. The reason why you should not suck out the air that you introduce is because in doing so, you're weakening the walls of the balloon. Now, the other thing that is going to be important is this. Notice this. This is an unlocked position. Now, balloon port should be left in the unlocked position. It should never be left locked. This position should only be done during intentional balloon inflation. When the red line between the port and the syringe is straight, that means to say no jog right here, the port is unlocked. The unlocked position will ensure that the balloon will always deflate or go back to its default deflated position. Always make sure that you leave the syringe deflated and attached to the port as shown in this particular slide right over here. You only close it when you're trying to wedge so that you could see the wedge pressure. And then of course, after wedging, you can unlock it. Okay. So I think the reason I put this over here is, again, it provides you with the schema or the schematic diagram of how this catheter or where this catheter is located. See, the catheter is going to be located in one of these blood vessels. And this is what I mean. As you inflate the balloon, it's going to move forward and it's going to move towards the smaller tributaries of the pulmonary artery. So that is the reason why. So supposing now that this is the pulmonary artery and the tributary of the pulmonary artery becomes smaller like this. So when you inflate the balloon, the catheter is going to move forward right over here. And when you deflate it, it's going to come back again to this side. Depending on the size of this tributary right here, you might not need 1.5 mLs. Sometimes you might just need 1 ml, and that's going to be enough to occlude it. And that is why it's important to know when it is occluded. And I will tell you by monitoring the pressures. That will be the next part of this presentation. In some instances, there might be an extra port, and this is a port when right ventricular pacing might be required. If we have a right ventricular pacer port, it's an orange port. This is very rare. So we only use this port for medications with the permission of the physician. We certainly don't want to give medications to this port because the drugs might be caustic to the pacer wire. So what are you going to do during insertion? If you were to be assisting with this procedure, you need to make sure that you observe a sterile technique. It's going to be very important because, as we know, we are right at the heart and therefore in the heart of central circulation. The patient will most likely be on a Trendelenburg position. And of course, as soon as the catheter is going to be at the 20 centimeter mark, which is approximately at the mouth of the right atrium. The one that's inserting it, either the cardiologist or perhaps the anesthesiologist, will ask you to inflate the balloon. The balloon is inflated, and therefore it's going to now move forward along with the flow of blood. And of course, we're going to make sure that we are going to monitor the pressures as the catheter is being advanced. We need to know the waveforms. Very important points during insertion. The balloon will remain inflated during insertion for obvious reasons I told you, in order to move it forward. And the other reason is to prevent the catheter from flipping or whipping the walls of the right ventricle. It is expected, however, that while passing the catheter through the right ventricle, PVCs can occur. And that is the reason why you should have the crash cart available and close by, so that in the event of an emergency that you will be ready. Now, before and after every waveform reading, make sure that you unlock and disconnect the balloon syringe, as this will prevent balloon rupture or over distension. Never lock the syringe with balloon inflated, because this could cause pulmonary infarction and occlusion of the pulmonary artery tributary. Once the catheter is in place, the balloon should never be inflated for more than 15 seconds or 4 respiratory cycles. And the other fact is that I told you that the PA catheter can soften inside the warm body, and therefore it can cause the catheter to either withdraw or to wedge in the capillary even without balloon inflation. And that is the reason why you need to know how to interpret those pressures or those waveforms whenever you have a pulmonary artery catheter. I'm going to show you a silent film. There is no sound at all to this film, just to show you the progression of the waveforms as it enters into the right atrium and as it goes all the way into the tributary of the pulmonary artery. The catheter is now in the right atrium, and therefore it's inflated. The catheter is moving passively now to the tricuspid valve. It is now going through the right ventricle and now to the pulmonary artery. And as you could see, this is where it's going to most likely reside. This now is going to change the pressures, and we now deflate. You see this where it is going to be, as you inflate it, you notice where it goes? It goes into the smaller part of the artery. So I'm going to replay this back because I wanted to tell you about or show you the pressures or the different pressures as it moves about. So as it goes into the right atrium, notice that there are AC and V waves. We have a right ventricular pressure, which looks like VTAC, and a pulmonary artery pressure, which has a higher diastolic pressure. And then, of course, we have a occlusive pressure, which looks like ventricular fibrillation. So we're going to go back to the previous slide in order to discuss this. So do you see now or have a visual on the different types of pressure waveforms that are going to be manifest as the catheter is going to move forward. When the balloon inflated catheter is going to go into the right atrium, obviously we're going to see a smaller pressure, and this is around 2 to 6 millimeters of mercury, and this is what's called the right atrial pressure. And as it goes into the right ventricle, that the right ventricle is a bigger structure, and therefore greater pressures are generated in this chamber, and therefore you see a rapid rise in the pressure. The systolic can be as high as 20 to 30 millimeters of mercury, with a diastolic of around 0 to 5 millimeters of mercury. As it moves forward, right over into the pulmonary artery, there's a sudden increase in the diastolic pressure. The diastolic pressure is 5 to 15 millimeters of mercury, and it still has similar pressures for the systolic compared to the right ventricle. And lastly, when it goes into a wedge position, the mean is going to be less. So it's going to almost look like this again from the right atrial pressure, because this pressure right here reflects which chamber of the heart, the left atrium. So let's go to right atrial pressure, and we know that right atrial pressure is also known as a CVP. Why would we access, or why are we interested with right atrial pressures? Well, measurement of right heart filling pressures is very valuable to assess intravascular volume, and of course also the functioning or efficiency of the right heart. We all know that cardiac output is going to be influenced by stroke volume and heart rate, but it also is influenced by its efficiency in contraction. And so this is going to be a reason why we would want to access the right atrium. The other thing is, of course, it's valuable to access this particular chamber of the heart in order to administer drugs through central circulation. And it could also be as a substitute for a intravenous access for patients who have poor peripheral access. So the CVP and the right atrial pressure represents right-sided preload, or the volume of blood that is found in the right ventricle at the end of diastole. We all know that CVP and right atrial pressures is influenced by venous return and, of course, cardiac function. The catheter is going to be measuring what is known as central venous pressure, which is equivalent to right atrial pressure. Whenever we're looking at CVP, the normal values of CVP is anywhere from 2 to 6 millimeters of mercury, or if we use water, it's around 4 to 12 centimeters of water. Now, there are some variations. Some books might say 3 to 7 or 3 to 8 and so on and so forth. But nonetheless, this is an average of what the usual values are going to be. So let's take a look at some of the determinants of venous return, because you remember CVP is influenced by preload and actually is going to be determined by two things. One, venous capacity. This is the maximum capacity. It indicates the volume of blood that the vein can accommodate. Venous return, on the other hand, is the volume of blood that returns to the heart. And lastly, central venous pressure. Central venous pressure is the pressure on the large veins in the thoracic cavity, meaning to say in the inferior and the superior vena cava. So if CVP increases, what happens to venous return? Will a patient with an increased CVP have more blood flow to the heart, or would they have less? If CVP increases, what happens to venous return? If a patient with an increased CVP have more blood flow to the heart or less, I said, there would be more blood. If there is more blood flow to the heart, what happens to end diastolic volume? It increases. This is the amount of blood that is going to be in the ventricles before contraction. There are situations wherein we might have increased CVP, and when there is an increase in CVP, there's usually an associated increase in blood pressure. We're going to have the situations when we have fluid overload, right heart failure, cardiac tamponade, pleural effusion, and also mechanical ventilation. This concludes our discussion on pulmonary artery catheters and right atrial pressures. Thank you.